Yes, I entitled my talk Relevance of Expectation, Preferences and Optimism for Treatment Outcome. So we are dealing a little bit with the treatment outcome as well. And the starting point for this talk was this slide here. This is a really huge picture of what all is relevant for expectations. And you see here down there is the expectation, and you see personal characteristics, you see previous experiences, psychosocial cognitive theory, physiological feedback, and a lot of variables are in there. And this huge work of Anne Bowling has about, I think it's 500 pages, and you can read it, but you can also cut it down a little bit. And what I did is I cut it down a little bit. So the initial title does not work. I added health, but nevertheless it doesn't work, so I cut down the information a little bit. So what I'm interested is in the treatment preference, the optimism, the verbal suggestions and their impact on expectations, and at the very end on treatment outcome. So we heard already there are big expectations, big beliefs. We heard already that there are little expectations and little beliefs, and I brought you one item of our questionnaire we developed here in Zurich, and this is read like, I expect that through acupuncture my complaints will disappear, means there is a treatment and there's a clear outcome that my complaints will disappear. So, and it's a personal expectation, which is, in my opinion, the same, like you said, a little belief. And it's not a general belief that I'm convinced that complementary medicine works, or it's not a general belief that I'm responsible for my health. But there's another construct that is optimism, which is in my talk. And in optimism, we have the life orientation test, LOT, and this is one item of this test. And it reads like this: in uncertain times, I usually expect the best. This is more this general one, the general belief. And in uncertain times, it's quite often, and it's a personality trait in psychology. In psychology, you say it is a personality trait, and this might be not able to be changed, whereas these expectations might be possible to be changed. And the last thing is preference. What is preference? You just ask the patient, do you want treatment A, or do you want to be treated by treatment B? That's quite easy. So what does this have to do with expectations and the treatment outcome? Expectations and treatment outcome, there are several cohort studies on patients, and they show mixed results. Mixed results means there are either positive results or null findings. And positive results, there's an association between the expectation and the treatment outcome. So, for example, in the study Claudia was involved, there was a twofold chance to benefit from acupuncture if you are convinced that you have high expectations and you have a positive expectation about the treatment outcome, then you have a twofold chance to benefit from acupuncture. And fortunately, that's a good part, there's no study with a negative effect. No high expectation study ever found a negative expectation and an association of a high expectation and negative treatment outcome. So you mentioned this quote that maybe high expectations might are also dangerous, but there's no study showing that. Nevertheless, there are some problems. There's no standardized assessment. I mentioned the LOT, Life Orientation Test. This is a kind of a gold standard for optimism. There are other gold standards around, but expectation, there's no gold standard on how to assess expectations. Therefore, it's quite difficult. You mentioned this study using an optimism scale, and you said, oh, it's quite close to expectation, but maybe other people would say, oh no, it's not expectation, it's just optimism. So it's really difficult. We have no standardized assessment. And there are also ceiling effects, meaning people tend, if they go to a specific treatment, to be convinced at the beginning, because otherwise they would not seek this treatment. They would say, okay, I go to another treatment, and so we have a lot of ceiling effects, meaning that people have at the beginning, or patients have at the beginning, very high expectations. And what is also important from this association studies, we assume that this is a linear process. The red arrow shows that there might be an expectation treatment outcome which is completely linear. The higher the expectations get, the better the treatment outcome. But we are not sure about that, if this is really the case. Maybe it is also curvilinear, like the blue one. You have to have at least a minimum of expectation that you can benefit, or if the green one, you have just to be not a denier of the treatment and just say, okay, it doesn't work, then you are already a treatment responder. So we are not sure how this association works, and most studies just assume that it's a linear association in mathematical models. So, and the next problem is there are not only patients' expectations, but also physicians or treatment providers' expectations, as mentioned by the dean, also contribute to the treatment effects. And we did a study where we looked at patients' expectations and we looked at providers' expectations, and we built clusters. And we built clusters, 6 clusters, and looked what happens if we combine their expectations and look, is there an association with the treatment outcome? So, and what we found is on pain, this is a positive response. The larger the higher the effect is, the more response there is given. And you see there's this group and there's this group. This group is called by us, it's called optimist. The physician is optimistic and the patient is optimistic. And here we have a group where the physician is partly optimistic and a part of the study participants, but in some not. But there's a good match overall. Some are in the middle, but also the patient is in the middle. So there's a good match. So they respond very well. But there is a group of, we labeled it as optimistic doubters. They say, and this comes back to the belief question, they say, it would work now for me. Acupuncture is a good treatment now for me, but I'm a little bit suspicious if it works in general. So they have doubts in general, and they do not respond very well. So these doubters, and so it's a complex thing that we cannot really assume that it is a linear association, and maybe we have to consider also the expectations of the providers in our model. So let's look at the treatment preference and expectations and the treatment outcome. What do we know about treatment preference? So there's a very early study of the group of Brian Berman, and I just show you this is not treatment preference, but this is a post-hoc treatment guess, and then the people were asked, and the patient were asked, what kind of treatment do you think you received? And there's a true acupuncture group and there's a placebo group, and in the group of the true acupuncture and in the placebo group, a lot of people thought that they received true acupuncture, even if they received the placebo condition. So, and at the end, there was a group, they said, okay, I received the placebo condition, and this was a well match with here. But overall, 50% said, I have no idea what I have received. Was it placebo or was it a real acupuncture condition? And what is important is the randomized control trial showed no difference between sham acupuncture and acupuncture. But if you split the sample into those who believed having received acupuncture, they were all responders, and those having not responded said, okay, I have been in the acupuncture group. So the interesting thing is maybe people change their beliefs after having received a specific treatment. And the second interesting thing is that randomized controlled trials, maybe this does not take into account these beliefs. And the third important point is it's a post-treatment guess. What happens if we split up people into their treatment options according to their beliefs, what they really want? And this was done by Claudia in an early study. And she randomized, or she asked the patients, about 12,000 patients, really a huge study, if they want to get randomized and get acupuncture treatment for free, or if they will be not randomized, and they have to pay about 10% of the money for the acupuncture by themselves. So they have the choice to get randomized or to get the acupuncture immediately. So this was a decision made by the patients. So, and the idea was to look, are the treatments effects different or are they the same? Because both are allocated to acupuncture. They receive acupuncture, those receive acupuncture. So, and at the end, they showed that the acupuncture versus the control condition, this is here, had a difference on the scale of 22 points, and the difference on the non-randomized, so this non-randomized versus the randomized is only 2.2, so only a 10 times larger effect versus control condition, and the non-randomized control versus the randomized group was only slightly different. Nevertheless, it was significant since it was really a large sample. So this doesn't make really a huge difference, but it makes a little bit of difference. But this has the disadvantage, you compare a treatment A versus a treatment A, and it's not too different. You have not a treatment option. You can either decide, do I want to be randomized or do I not to be randomized? But what happens if treatments are equally effective? So this is a meta-analysis. We did a network meta-analysis, a difficult word, on psychotherapy for depression. And you see these plots here, and you can say, okay, it doesn't really matter if you go to a psychodynamic treatment or you go to an IPT therapist. It doesn't really matter. You do not have to understand all those acronyms. The take-home message is, it doesn't matter what you do, okay? So, and then you have the situation that patients would be able to decide, should I go to this kind of treatment or should I go to this kind of treatment? So, and these are preference-based trials, and this is a two-stage randomized controlled trial. And in the first stage, you say, okay, I randomize the patients to either these conditions where patients are randomized to treatment A versus treatment B, or I randomize patients to the group where they can decide if they want to get treatment A or treatment B. So, and the earlier question was, is treatment A equal treatment B or A versus treatment B? But this is not interesting in this context. The more important question is the treatment A, if we give it in a randomized controlled trial, or if it is pre-selected by the patient, equivalent to those here and B versus B here. This is the very important comparison. So, and Swift did a meta-analysis of all available evidence in psychotherapy outcome research, and they found an effect size that it matters about, and the effect size was 0.30, and it matters that if patients self-select their own treatment, then they have a better outcome. And this is quite an impressive thing, because we earlier read these numbers, which are about 0.70, 0.80 as treatment effects, and 0.30 is quite a large magnitude of the effect. So let's have a look at optimism, pessimism, expectation, and treatment outcome. I do not talk about pessimism, even if it would be maybe more powerful, but I like to emphasize the positive way of thinking and looking at expectations on the positive way on treatment outcomes. So, what is optimism? Optimism, according to the definition of Carver and Shire, is an individual difference variable that reflects the extent to which people hold generalized favorable expectancy for their future. That's a sentence only a psychologist can write, read, understand, and reproduce. It's really difficult, but the very important thing is the generalized favorable expectancy. So it's related to our topic, but it's a general thing. So, and optimism improves health and increases treatment effect. So we have better treatment outcomes, we have better stress responses in experiments, lifestyle, etc. This has in numerous studies it has been shown. So the the problem is, can pessimists become optimists? If you say it's an individual difference, you say it's trait. You cannot change a pessimist into an optimist. It does not really work. But we heard about positive psychology. So, and one person in positive psychology is she developed such interventions to manipulate optimism. Yeah? And this is the best possible self as an intervention strategy, and it's a writing exercise. And in this writing exercise, you get an instruction. Think about your life in your future. Imagine that everything has gone as well as it possibly could. You have worked hard and succeeded at accomplishing all of your life goals. Think of this as the realization of all of your life dreams. Now write about what you imagined. So, and people have to do this exercise sometimes, and there's a short-term effect of mood and optimism and some other health outcomes. And the conclusion overall is optimism can be changed. But does it matter if we change optimism for the treatment effect? That is the next question. So, and this is a study on experimental pain, and they used the same instruction and instructed the students to write a letter of the best possible self or of a typical day. Yeah? And they did a cold pressure test, and those of you who are familiar, they feel pain right now. For those who are not familiar, I will explain shortly. You have a large a bowl, yeah, thanks. A bowl, a large bowl with ice in there and water, and you put your hand in there. So, and it's really painful. So, and here you see 20 seconds, 40 seconds, 60 seconds. And if you imagine your best possible self, you are doing much better in this task. And if with less pain, and if you have a typical day instruction, you're doing worse. So just imagining and changing optimism in advance of such an experimental stimulus can maybe change as well the pain perception. So this is experimental work. And I think there is more to come, because these are just recent studies, and the disadvantage is optimism has not such a long tradition as other things to do, and the interventions are coming up right now. So verbal suggestions and expectations and treatment outcomes. There's a new meta-analysis of Perelman from the Netherlands, and she looked at all the studies using patient stimuli on pain and looked if verbal suggestions can change the experience of pain. And overall, there was an effect size of 0.75, meaning if you give positive instruction that you can cope with the task, that you can cope, and they have a powerful intervention, you get a drug which is sufficient dealing with your pain, then you can convince people that they experience less pain. So the disadvantage is it's only experimental pain. So can we bring it to a more applied setting, because an effect size of 0.75 is really huge. And just by a verbal suggestion, it is a little bit an overestimation of the clinical routine finding. So there was another study from a group doing the same in acupuncture of the knee, and they looked at the manipulation of expectations by using high expectation instruction, and they gave this instruction to the acupuncturist, and they say, oh, I think this will work for you. I have a lot of success for treating knee pain. Most of my patients get better, and so on and so on. And they were trained to use a high expectation communication style, whatever this means. So they give such instructions in a high expectation way before the patient get the treatment. So, and the neutral expectation group received this information. They said, okay, it may work or not work. It really depends on the patient. We cannot really estimate what happens afterwards. And they get a brochure as well, and the acupuncturists interacted in a neutral style. I would not say it was a frustrating style in a neutral style, but it could be as well a little bit frustrating. So, and what was the effect about over 3 months? There was a significant effect. There was a little bit the problem that there was already an effect at baseline present, and the effect size is of about 0.25, indicating that those in the high expectations group did much better than those in the neutral expectation group. So it brings this number of 0.75 of Perlman a little bit into a more clinical relevant context that you are able to change by expectations as well, pain. To summarize, expectations are connected to the treatment outcome. We would say probably yes. The cohort studies showed us this. In these experimental pain conditions, we showed this as well. The intervention strategy to use expectation, the changing of expectations by verbal suggestions could be a way to improve health outcomes at the end. So I voted probably yes, and its expectation could not be mediated by expectations. But looking at optimism, optimism is clearly connected to the treatment outcome. A lot of studies showed from Carver and Shire that this is the case. And I also opted for a probably yes here, that it is as possible to use optimism as an intervention strategy, like in this instruction, this writing instruction. It could be helpful. And is it mediated by expectation? I would say yes, because if you give suggestions to write about your best day in your life or a good future, it is always mediated by expectation in your treatment outcome. And a treatment preference, I would say it is connected to treatment outcome, probably yes, or it doesn't matter. And is it an intervention strategy? I think it's not an intervention strategy per se, but it is implemented in healthcare already in the term of shared decision making. If you say, okay, we have different options, which one do you prefer? You have already integrated this in the healthcare system. And is it mediated by expectation? I would definitely say yes, because you activate expectations by asking patients what they really want. So this was this overview. I hope I didn't disappointed that I only selected 3 items of the bowling figure, but I think it was a reasonable decision to cut it a little bit down, the information. Thank you very much.
Thank you very much, Jürgen, especially by showing that the field is much more complex than we sometimes think and that we only know bits and parts of it.